So without further ado, it is my privilege to introduce my colleague, my dear friend, and today's keynote speaker, our Senior Vice President for Health Equity at Grady, Dr. Yolanda Wimberly.
Good afternoon, everyone, and good afternoon to those online as well. I will, because we have people online, I'll kind of stand behind the podium for most of the presentation today. But I'm Yolanda Wimberly, and I'm excited to be before you today just to talk to you a little bit about what we're doing here at Grady. My title is now the Chief Health Outcomes Officer, and we in our office are now on a journey. I guess now it's about 3.5 years since we started. And so I want to just take you step by step through the process to show you how did we begin, how did we determine what we wanted to do, and then how do we put those thoughts into action. Just do this. Oh, okay, just do that. Okay, so from awareness to action, creating the conditions for sustainable engagement and meaningful change. Within the health equity space, or just within health outcomes space in general, you know, a lot of things have been done around, you know, where are we? What are the needs? One of the things that I brought to this position that I thought was quite unique was the fact that I was already a practicing physician. That makes a difference sometimes when you come into these offices and you're doing strategic plans and you're kind of strategizing about how you're going to make an impact. So keep that in the back of your mind as we go through this presentation. These are the objectives that are up on the board for you as to what we will cover today. So we will analyze health disparities by zip code in Atlanta. We will apply evidence-based strategies to advance health equity, and we also will commit to physician leadership and health equity. One of the biggest questions that I always get asked is, how can I myself, as an N of one, be able to contribute to health equity at Grady? Because at the end of the day, no office is going to be able to make this change. It's going to have to be each and every one of us working together. And so we'll get to some solutions for that as well. So the first thing I always like to know about people is a little bit about their background, because what you're going to see is that's going to really show in the passion and the commitment that they have to a purpose. And so for me, as Dr. Manning has already told you a little bit about myself, I'm an adolescent medicine doc. So I take care of teenagers most of the time. Unless I'm forced to do birth to 26, for the most time, I will do 12-year-olds to 26-year-olds. I don't know if you guys know any other adolescent medicine physicians, but we tend to be a little different. We tend to just have a different type of personality, a different type of thing that probably drew us all into this particular field. So working with adolescents, I guess 29 years for graduating med school yesterday, probably about for the past 25 years practicing clinical medicine. What that allows you to do is that allows you flexibility. It allows you an opportunity to really think about the what ifs. It also allows you an opportunity to really look at the youth to determine how that can charge forward for the future. And so just thinking about what that looks like. I am a hospital administrative executive. This is new for me for the past 3.5 years. I call myself a compassionate leader because I feel like you have to do things that you're compassionate about and that you have a passion for. Otherwise, it'll just be work. I think that I'm a visionary in public health and outcomes and how to change things. And I'm also, most importantly, a dedicated wife and mother of 2. Now, why would you put that in there? Why would you put the personal piece in there? Because that personal piece in there is also another driver of the passion. Because if I'm doing this just to make things better for Grady, or am I doing this to make things better for my community and also for my family? A lot of times with that makes a difference with this work. because this work can be sometimes very challenging. And sometimes it is kind of, you're in it for the long haul. And so you have to always have these things to really center you. And so these are just some things that I think of daily. My commitment to caring, paving the way for inclusive healthcare. So let's talk about our story at Grady and how we started. So the first thing that you have to do is you have to have a vision statement, right? So at Grady, when I first came in, I'd been practicing at Morehouse School of Medicine for 20 years, over at Hugh Spalding, did a couple of clinical experiences here at Grady, but primarily was at Hugh Spalding most of the time. So when I arrived at Grady in October 2021 for this position, the first thing that Mr. Harpert asked me was, he said, you know, Dr. Wimberly, we need to get a strategic plan together. Okay, I said, okay. Well, what is the definition that Grady Health System has for health equity? I don't know, we'll have to figure out who knows where that is. So we didn't have a definition of health equity. And I said, the first thing we have to do is define who we want to be. So I did what any other person would do, which is do a Google search, right? How many things did you think I found on the Google search? Tons, right? There's tons of definitions of health equity. It really depends on where you want to focus. And so after much ado, after about 2 weeks, we just decided to go with the Robert Wood Johnson definition. After we figured that that definition probably hit all of the things that we wanted to see, we said, okay, we're gonna go with this. So that's the first part, is just getting the definition of health equity. So once we have the definition of health equity, the next thing you have to say is, we know what we are, but what is it not? Very firm from the beginning to say that this has to be an action-oriented office. We are not an office that are going to write a lot of white papers. We're not an office that's going to do a lot of evaluation. We are a healthcare system. We already know a lot of the information that we need to know to be able to move forward. So just as important as knowing what you are, it's important to know what you are not. So we're just not about treating illness. We're not solely the responsibility of healthcare providers. Health equity is not something you think about when challenged by the community or the media. Somebody puts a mic in your face and then you say, okay, let's think about what we're going to say. We are not only about individual outcomes. We're not a quick fix, a static goal, but it's something that we have to integrate into everything that we do. If we are not working from that context, that health equity or positive health outcomes should be something in everything that we do, then we will fail. This office is not to be the office that does all health equity projects. This is the office that helps to facilitate, support, and provide advice for integrating equity in everything that we do. There is a difference, and we talk about that quite a bit. There's an ownership of that. So now that we have that, we said, okay, well, we need to get an advisory board. Everybody has an advisory board. I guess we need to get one, right? So we got an advisory board. It's called the Grady Health Equity, Diversity, and Inclusion Advisory Council. This was made up of people throughout the community, as well as some of the leaders at Grady. And what we were able to do was to come together as a group to talk about, to form like a think tank. What is it that we want to achieve? What is it that Grady, specifically in the realm of health equity, needs to focus on? That was really the sole focus of this group that met on a monthly basis. It was hybrid, so people came in person. We had virtual people. We had people who were leaders in health equity space nationally, but we also had people who really didn't know anything about health equity at all. So as far as the variety of people that served on this 38-person advisory council, we had lots of diversity within that advisory council. So for about the first 8 months, they were very, very key in really guiding our strategic plan and what that output looked like. How many of you guys are familiar with this, the Health Equity Roadmap from AHA? So the American Hospital Association, so when you come, because I came out of academics at Morehouse, and then I came into the hospital side, there's a whole nother group of organizations on the hospital side that I had to learn. So AHA is probably akin to our AAMC. Okay, and so essentially, American Hospital Association had this health equity roadmap for hospital systems that they wanted us to complete. It is probably about a 10-page document that asks tons of questions, asking about where you are in different levels as it relates to health equity. And at the end, you get a grade. So I looked at the health equity roadmap, and from what I could tell, because I had been at Grady for 22 years before taking on this administrative position, I told them, I said, so let me just ask a question. If we fill this out, we're probably going to be red. You want us to fill it out? I mean, that's a real question. John Harper said, absolutely. I said, okay, I'm just letting you know we're going to be red because I've kind of looked at it and scanned it, and I already know we're not going to have answers for some of these questions. And he said, yes. So we filled out, we were one of the first hospitals in the country to fill out the health equity roadmap. We were actually yellow in a couple of areas, so that was a good surprise. But you know what it did though is it served as a baseline for us. In this work, it's important to make sure that you take that data and that it has to drive it. And so I knew that this was very important for us as a starting point to say, 2 months after this office was established, this is our baseline assessment from AHA, which is an organization that hospital systems find very credible. So I had to be strategic in my thought process with this office as to how do we do this? Who do we partner with and what do we complete? So we did the health equity roadmap, which was great. Then after that, I had to look around to see with this Office of Health Equity and this reporting structure, when I came in, I reported to the CEO directly, which was very important for this office. And the reason that you want to report to the CEO is because you have no filter. You can go and report directly to the CEO who reports to the board of directors. So that was going to be very important if we wanted to be actionable and move things forward. In addition, what we needed to know was the lay of the land. So what are other hospital systems in this area doing? How is their reporting structure for their chief health equity officer? And so as you can see up on the slide, we had Grady, Emory, Piedmont, Northside, Wellstar, and then CHOA. And so if you look here, and it's going to say board oversight, which is the second row. That's really what I was looking at. And as you can see, everybody was red on that slide except for Wellstar, which meant that their health equity office did not have a board level committee. They pretty much stopped, and then it's up to the executive leadership team to bring that up to the board level. Then we looked at public and private safety net organizations. So we took it outside of just Metro Atlanta and said, okay, what about some of our other counterparts? And as you can see in this same second row, which is what we were looking at, Cook County Health is the only one that had a direct report board oversight of health equity. And so once I figured that out, it was important for me to have a discussion to say, if this is something that we really want to move forward, we need to consider getting board oversight. What that means is that at the board level, that there is a committee dedicated, like they have finance, they have comp, but it has to be dedicated to health equity, to raise it to that level for credibility, also though for accountability and for resource allocation. And so that was what we found when we did this initial kind of, remember, I'm still in my first 6 months and I'm trying to figure stuff out about how we're going to do it. So in the meantime, we developed a strategic plan. Prior to development of the strategic plan, we did something called listening tours. So how many of you guys are familiar with listening tours? So people who come in and they say, okay, we want to go around and talk to people and see how they feel. That's what I did for like the first 2 to 3 months. So I met with groups of about 10 to 12 folks, all different areas. So down from EVS services, frontline folks, receptionists, all the way up to the chair of the board. And they were in groups together. And we talked about, I asked them 3 questions. I'm gonna ask you guys these 3 questions. Somebody tell me this. What is the definition of equality? Just one person yell it out in person. What's the definition of equality? The same. Okay. What is the definition of equity? Mhm. Get what you need. Okay. What is the definition of health equity? So those were the 3 questions that I asked over 300 employees at Grady. Okay. And they kind of did kind of like y'all did, right? Except I had a whole hour with them, right? And it was interesting because at the end of my tour, I said, I am now the inaugural Chief Health Equity Officer, and people don't know what I'm supposed to do. Because what we found out that there was a foundational point of allowing people to understand what health equity meant. A lot of people had heard it 1,000 times, but it had become a buzzword. And to be able to put it into play to make impact and make a change, you have to move people from the fundamental concept to how can you make that action. And so that's what I did for the first 3 to 4 months was these listening tours. And we actually wrote it up, had it published in the Journal of Healthcare Management, and actually received an award in March from ACHE for the best paper last year in 2024 for that. But we talked about those listening tours and just kind of what that meant. The upshot of the paper basically showed that from the outcome of our tours, people really didn't understand the definition of health equity. And as we start to open these offices up, we need to make sure that people really understand the fundamental principles. Practically speaking, what did that mean for me and my board? That meant that we now need to make sure that our strategic plan should be as simple as possible and as action-oriented as possible so that people can really get to understand what that means. So up here, we put it in 4 pillars. And so we have our pillars, we have care quality, we have community engagement, we have cross-cultural empathy, as well as social justice and advocacy. And with those, we have links. And so we have a total of 10 strategic priorities, and all of them are linked per pillar. The pillars make it easier for a lot of people to understand because they'll say, okay, I'm on pillar 2, I'm on pillar 3. And so that helps us to really understand as we are advising the entire organization what that looks like as to their programming or projects or integrations that go along with that. And so voila, probably about 6 months later, we had our strategic plan. And so if we look at it, that first pillar, I want to just break it down just a little bit. That was access and care standards. What we found was that access was really what we were going to focus on. The thing with health equity or health outcomes, or however you want to call it, whatever you want to call it, is that you have to be able to have something to focus on. What we found was that it was, hey, can you do a health fair over here? Hey, can you do this? Hey, can you do that? And I was like, I mean, health fairs are great. They really are. When I was at Morehouse, the residents did a lot of health fairs. But this was like, from this office, I said, we can do community programming, but we're doing more than just health fairs. We got to make an impact. And so what we started to do was to say, okay, how can we couch everything that we do has to center around access? So everything we do has to link back to access, and strategically, only thing we say yes to are things that are really within that wheelhouse. And that was very hard to do because people have great ideas about things you should do. They really do. They have a whole bunch of great ideas about how you can do something. But our biggest piece when we first started was being able to streamline. And I don't know if Dr. Mobley is back there still, but Dr. Mobley, oh yeah, she used to always say, Dr. Wimberly, let's just think about this before you say yes. I hear that in her mind when people ask me stuff, because we have to stay focused or you won't have any type of an impact. So for access, we really looked at cancer screenings to meet national standards. We looked at SDOH. We looked at MyChart access and health equity accreditation. Those are 4 pretty simple things, measurable, not too hard to do until you dig in and try to do them, right? So let's look at MyChart access. Increase patients' MyChart access to 90%. How many of you guys are familiar with MyChart? Okay. MyChart gives you what? Instant access. I can communicate with my patients. They can make appointments. I can contact them. Has you ever thought about when you guys are seeing patients, do you know how to look to see if your patient has signed up for MyChart access? Okay. How many of you guys, when you see that it's not a green check, do you do something to make it be a green check? Little simple things. These are things that we at the physician level can do to help out. And so when we look at MyChart access for Grady, how many of you guys know what percent MyChart access our patients that we're privileged to serve, what percent of our patients have access to MyChart, have activated it? You guys know? Anybody want to take a guess? 60, 30. So when we started off, it was about 55%, which is actually pretty good. Now, I'm a pretty competitive person, pretty good relatively speaking, right? But when you look at best of standards, they're about 90%. So we started to say, okay, what type of campaign can we put together just to get patients signed up for MyChart? So we looked at the reception when they check in. So we said, okay, can we set something up so that the folks who are checking everyone in can just do MyChart access? Sounds pretty simple, huh? No, it's not. Because first of all, they have to know how to do it. A lot of them didn't know. So we had to do a training so that they did know. But then I had to look at all of their responsibilities of things that they're already doing. And now you want to add this on. So we had to have those conversations too. So it took maybe about 2 weeks, which wasn't long, but we were able to really incorporate that into one thing that they do. So one of the things that they do now is if it's not a green check, they make sure that they have a green check. So little simple things, but things that are going to be systemic and sustainable. So now our rate is actually at 85%. Just from doing these, and I tell people, it's the little things. It's the little things that you do. And I had a competition with my residents, and I said, anybody who has at least 90% or more of their patients with MyChart access. And I showed them how to look it up, because you guys know you can look at your own data with your patients, with your gap analysis and all of that stuff for your patient panel. And what that does is that teaches people to be cognizant of that, but it's a community approach. The other thing on here were cancer screening rates. When I first started with the Office of Health Equity, our cancer screening rates for breast, prostate, cervical, lung, and breast, prostate, lung, and colon, thank you, I always forget colon, it's 5 of them, were low, okay? Now, what we ended up saying was, why are these low? We had to kind of go into it to say, is it the physicians? Are the physicians ordering it? You know, they always, it's always the physicians, right? That's why I love that. Are the physicians ordering it? So we have to look at that. Should the physicians have to order it? Should it not be something that can auto order? Do we have to order it, or can we just do auto order? If somebody is 40 and above and meets the criteria, it should automatically do it, and then they get scheduled for the test. So we had to look through all of those things. And so this is kind of how we strategically thought about this access piece. And then SDOH screening, the same thing. How many of you guys are doing SDOH screening with your patients? So in clinic, when they come in, as the physician, or if we have any APPs in the audience as well, I always look when I see my patients to make sure that their SDOH is completed. And if not, I will complete it myself, because often, most of the times that are in there are things that we're always going to be asking anyway. And so I just kind of wanted to give you guys some practical things as we go along as to some things you can do. This right here, this is our SDOH inpatient screening. How many of you guys know that we're now doing SDO inpatient screening. So therefore, if you're on inpatient, before you discharge your patient, you can just simply make sure that the SDOH screening is complete. Oftentimes, it will take you as the provider probably about 2-3 minutes to do it because you already have the information. It's just a matter of documentation. And so that's one thing that you can definitely do with that. But we've been going on this project now for about a year, and we've actually gotten up to about 80%, which is good. We started in the outpatient about 2 years ago. And then another thing that we do when we look at access, and we also look at our care quality, is looking at our patient safety measures stratified by race and ethnicity. And so essentially what we do is we do this on a monthly basis. But what we see is we look at adverse events to make sure that there aren't any trends. We haven't necessarily seen any trends with race ethnicity, but you may see trends with floors. And so that's important. So if we see trends with particular floors having more adverse outcomes, then we need to go and probably help assist that floor to see what's going on. And so this has been very, very important for us. And this is one of our inpatient, or I guess it's interesting because people put stuff in the inpatient and outpatient boxes so much. It's actually interesting when it should all kind of flow. But this is one of what they call our inpatient measures. And so we can look at that to see if there are any trends that are developing. And this is something pretty new that we started to do in conjunction with our quality office. And then we also do it by zip codes. And so in a second, I'm going to talk to you about our zip code work, but we look to stratify by our top 5 zip codes. And so you can see if there's any trending. We really didn't find any trending info there either. The only thing that we found was by floors. We also have a health equity board metric. We have a health equity dashboard that we built. And hopefully you guys can see that, but essentially it took us a year to build this. And we actually pushed a year. This has so much information in it that it is really impressive. So essentially, we can go in, look at our patient data for all the patients that we have at Grady, and we can stratify it by all of the cancer screenings. We can stratify it by zip code, race, ethnicity, SOGI, everything. We can slice and dice and stratify and have up-to-date information. This was important because as we move through, it's important for us to understand the impact that we're having. And so this dashboard was actually put together by, it was led by Davis Burgess and Andrea Mayo, but they did a great job of putting this dashboard together for us so that we have data on a monthly basis. It updates, and so we have data. This is what we use for the board. Because the board was, when you have a board level committee, it's a little bit of a different demand. And so they want data on a regular basis. And so this has probably been one of the biggest things that we've been able to do within health equity. And a lot of people across the country ask us about our dashboard. So our community engagement programs, that is going to be our second pillar. And so how many of you guys are familiar with TELP, Teen Experience and Leadership Program? So we've been having that for about 4 years now. And the first year, it started off with 80. The second year, 237. The third year was 597. This year, 683. So essentially for a 6-week period of time, we have teenagers who come to Grady and have shadowing experiences. I love this program because every year we get better and better. This year, what we decided to do was the students will come in 3-week blocks, which allows us an opportunity to scale. But this is our workforce development. They are our future. And it's important for them to be able to, A, get experience and exposure. B, it's great for Grady. I would say probably about 95% of them coming have never stepped foot on Grady's campus before. Probably about 50% of their parents have called me to make sure it's safe and this and that. It's very interesting. It's very interesting because The only time people see Grady is when something bad happened on the news. And so it was very interesting because the parents will say, is it safe, Dr. Wimberly? Do you think it's safe? And so I think we are really shattering a lot of misconceptions with this program, because right now we've had over 2,000 teens who participated, and they are our ambassadors. And I'll tell you, they get Grady swag. And when I go to my kids' football games and stuff, I'll see them, they'll have the Grady shirt on. At graduation, somebody had on a TELP jacket. I mean, it is just wonderful branding as well. But I'm telling you, this has probably been one of the best things that has come out under this pillar for community engagement. And I want to just take a second just to show you a little bit of a video, because that's going to tell you a lot more than what I could. You can hear it out there. From an idea about how to expand the healthcare work.
Help is important at Grady because it's going to expose kids from.
You don't know how to do it? That's fine. Okay. That's okay. We can just turn it off. I can send it to them. But we have a video, and I'll send a link to you guys, but it's really good. It's we have a Office of Health Equity webpage too on the Grady website under About Us, and it has everything on there. It's a pretty neat video. Okay, can you turn the video off? Okay, let's see.
Corporate and legal affairs, different parts of healthcare that people might not think have anything to do with the hospital.
Being able to see patients, shadow an operation, everything like that.
Yeah, I just stopped it. Thank you. I'll send that to you guys, but that is the program, and it's actually about to kick off on May 27th. And on May 27th, it'll go through July 14th. Are there some things that you guys can help us with? Oh, definitely. This is a summary of our participants for this year. And so as you see, we have 683 students. They'll come through 350 and 350. So it sounds like a big number, but we've chopped it in half, actually. They come for 3-week in-person shadowing experience. Most of them do about an average of about 4 to 5 sessions. And then we have them from 17 of 159 counties, 118 zip codes. There's 735 zip codes in Georgia, and then 153 unique schools represented, with 75% of them being public schools, and then about 88% between 15 and 17-year-olds. So we have a TELP research symposium that we do need help with. Anyone who is interested in serving as a mentor for our TELP students, we would definitely be interested in having you on board. As we move now to our cross-cultural health equity strategy priority with Pillar 3, this is really, I think about it as looking internal. Okay, so when you're talking about internal things, HR at Grady still does all of the internal things. But what we do is health equity, because we're out-facing, our department is out-facing. We're looking for targeting job recruitment of young adults. What percent of Grady employees, we have about 10,000 employees at Grady, what percent do you think are between 18 and 24? When we first started out, it was about 10%. So not a lot. When you're talking about sustainability, longevity, when you're talking about those types of things. So over the past 2 years, we've been working really intentionally with HR to open up entry-level positions, to offer on-the-job training. They now come to all of our TELP experiences and recruit people, especially because we have some kids in TELP who just graduated high school, do have a high school diploma, and to work at Grady, all you have to have is a high school diploma and/or a GED. No prior work experience is required. And so we're able to we start to look at kids in Job Corps, we start to look at kids who are in technical colleges, and so really leading efforts with them to increase the number of 18 to 25-year-olds, but also wrapping them around in those services that they need. It is a metric-driven performance evaluation. So now we have the Office of Health Equity is actually a metric on our performance evaluations. So when we talk about the institutional criteria, health equity is now one. And this past year, we had 109 leaders actually select health equity as one of their outcome measures. And an outcome measure means that if you don't meet your measure, you don't get your bonus. That's pretty much the end result of that. And so we were very, very happy to see that so many of our leaders had selected health equity as one of those measures that they tied to their bonus. That shows you that somebody is really committed, because they really are putting their money where their mouth is on that one, huh? Because if they don't make the metric, they don't get the money. How many of you guys know that we have a deaf nurse at Grady? You guys know that? Okay. Yeah, we have a deaf nurse at Grady. We just really celebrated her last week for Nurses Week. And her name is Ogechi Mbaki, and she has been fabulous. She's been at Grady now for about 18 months. She came to us out of training at Georgia State, and we totally worked to make sure that she was able to practice effectively here. Now, having a deaf nurse, and that's what she prefers to be called, deaf nurse, that's why we're using the terminology that she prefers, was quite interesting. It required some adjustments. It required some outside resources that we did not have. It required a monetary contribution as well to be able to get those resources. And I'm happy and proud to say that at Grady, we did it. We did it. This is something that is not necessarily seen nationally. We did searches of it. We only found one other deaf nurse that was working on the inpatient setting. That was at Ohio State. And so as far as we know, we are probably one of the few in the country to do that on an inpatient setting. What that does tell you, though, is it tells you the commitment. It tells you just the drive that people have. But I really wanted to bring this up here because I think it's important for us to know that, because that is a huge sign of progress and impact, that an organization would use resources to be able to do that, to onboard, and to serve as a best practice across the country as to do it and how to get it done correctly. But yes, we're celebrating her. We celebrated her with the Trailblazer Award last week at the nurses. And I'll send this out to you, Dr. Manning, so you can send it out to the group. We have a whole write-up on it about her. Now, we talked about the board committee. And what I wanted to show you was just, if you look here, diversity, equity, and inclusion, less than 5% of institutions across the country had that at the board level. And so we have that here at Grady. And these are just some of our committee priorities. And so this year, our committee priorities are health literacy and health equity research. And so every year, our board of directors chooses priorities. And so now, health equity, you guys see that, is the second rung on our strategic plan. That's new. Before, it was just 4, and health equity has now been included in our strategic focus areas institutionally. So once you get it up there, and then you have a board committee, you have accountability. You have performance-driven metrics. You have achieved a lot. And I'm so proud of Grady for us being able to achieve this in a 3-year period of time. because what it does is it gives you sustainability and it makes you feel like the organization is really, really, really invested in this. And so how many of you guys have heard of the IB program? The IB program with trauma. So we're starting to we work with the IB program. For those of you who don't know, it's folks who have been affected with violence, our patients, and then we follow them. It's about a 1-year program, but their enrollment rate has drastically increased. We have Flowing with Blessings. Today is Tuesday. They're probably out there from 10 to 2 every Tuesday and Thursday for the past 3 years. They're outside. They've been on the Kelly Clarkson show. They've been on NBC News nationally, and they're right out there. They do unhoused showers for the unhoused, as well as washing clothes as well. The washing clothes piece came from Heidi. So what we do is a lot of the trash that you see on the streets due to the unhoused is due to clothing. And so Nikki came up and said, Doc, I got an idea. We should get a washing machine that washes and dries in 30 minutes. I said, you've never washed before, have you? Because I know my new washing machine, it takes like an hour and a half to wash clothes. I'm like, what are they doing? You know, the old ones maybe, but the new ones, it just takes a long time. And so we were on the Heidi advisory board one day, and I just joked about it. And actually it was Gary Clifford. You guys may know him, Emory. He's on there. He goes, hey, I think I could get some people to do it. So he connected them to some people. Long story short, Georgia Tech students made that their senior project. So I think it was a year ago, the Georgia Tech students developed a washing machine dryer that would complete the cycle within 30 minutes. And that's what he has on the bus out there. And he has about 10 of them. And so that came out of that. But anytime you guys want to do anything, he is always there. These are just some of our numbers, because remember, I have to keep the data. These are just some of the numbers and the matrices that we have. And as I close out, I did want to get, though, to the zip code. The zip code information, this is what I want to close with. So looking at the life expectancy was a big thing that we wanted to do. So when you think about what to measure, you say, okay, the outcome of everything is going to be life expectancy. And as you see on this chart, in Metro Atlanta, depending on where you live, there may be a 13-year difference in life expectancy, despite the fact that somebody may only be a few miles away. And why is that? I think we all have a sense of a little bit of why it is. But what we wanted to do was to say, okay, let's look at Fulton and DeKalb County. These are the counties that we service at Grady. Let's look at the life expectancy in all these zip codes. And so what we did was, you see the legend here, 72 and below, and then on up, you guys can read that. And so we shaded it and we said, okay, this red is coming right in here, right? It's right in here, the red. And then, I don't know if you guys can see this may be clearer, but what's right in the middle of the red? Grady, right? It's the Grady sign, it should be up there. So the question becomes, if you have areas of red that are low life expectancy, and we're located right in the middle of it, what does that mean? We didn't have an answer. Because you can talk about transportation, you can talk about other things, but it kind of is staring at you in the face. It's about access. How many of you, if you meet somebody on the street, can tell them the number to call to make an appointment at Grady? Somebody can stand up and tell me that. You can tell me? Okay, how many of you guys knew that? Y'all just didn't want to say anything? Okay, so I had about 10 people, but how many of you guys didn't know that and practice at Grady? So that's something that we should know. So it's about access, right? And so what you look at is, if you can see, we also made it so that it was inside 285 and then you had 20. The red, and I'm sorry for y'all online, but I'm about to go out here for a second. The red, you see how it goes 20? Along with the interstate. And look over here in DeKalb. DeKalb doesn't have as many reds as Fulton does, but look, Do y'all know those exits off the interstate? Who knows 20 going east? What's that exit? What's these exits? Wesley Chapel, Candler Road, Gresham, all of that. It's so funny, wherever I drive east, I think about this map. But look at there, it's right there for a reason. What's that red up there, y'all? That's Stone Mountain over here.
Clarkston.
Oh, I'm sorry, I was talking about Clarkston.
Yep.
Clarkston. So if you think about it, Clarkston as well, it makes sense. So if you start to map out what that looks like, then we know where to go. We can go to some of the blue areas, but we're going to focus in the red areas. And we're going to do our data and our metrics based off of the red areas. So once we got that together, we did what we call a community profile. So we took it and we looked at our age cohort, race, ethnicity of that particular zip code. We looked at the lowest 5 life expectancy zip codes. Now, 12 of them had red, which was sad. We couldn't do 12. That's biting off more than you can chew. So we said 5. These were the 5 lowest, 30310. How many of you guys know where that is? It's right up the street. 30310. What's the zip code for Grady? 30303. So a lot of these zip codes, you'll be able to figure it out within close proximity. So that's the age cohort. That is the demographics. 53% female, median age 38. Then we did what we call a data form. So for zip code 30310, we mapped our Grady data. Inpatient discharges, outpatient visits, unique patients, ED department visits. And then we looked at our breast cancer, cervical, colorectal, and lung cancer screening rates in those areas. And as you can see, we were looking to be at the national standard, which would be about, at the end of the day, about 80%. But we had some metrics in between. And then you guys see here on 2/8/24, and then over there it says 12/31/24. This lets you know the impact. You see that red that turned not red? That means that we had the significant impact and met that metric. So that's how you're using data to tell the story. So what do we do to get those numbers down? Targeted approach. So we have health equity access coordinators. We look to see in 30310 zip codes, if we have 6,000 Grady patients in that zip code, let's do a gap analysis and see what are the cancer screenings that they're missing, and let's call them and get them in. Targeted approach, intentional. What do you think most of them said when our health equity access coordinators called them? I've been trying to get in touch with y'all. I'm so glad y'all called me. That's what we got a lot of, because access is an issue. That's how we were able to get those numbers up, because they were really people that were waiting, but for whatever reason hadn't been able to get in. That's how we show that. Same thing, so we did that. I'm gonna go through these quickly. We did this with every other zip code, 30310. You guys can see this is a trend where they're all in the same areas, 30314. Same thing. But what do y'all see that's not changing? Colorectal is not changing, right? Colon cancer. So what do you think my board has told me the focus is now? Colon cancer. We want to talk to the colon cancer people. Everything else is changing but them. That's what the board helps you with being able to focus and have the resources. And the colon cancer, my GI docs, they have been amazing with responding and with telling us what they need to be able to get the job done. So that's been really helpful. So I'm going to close out here, but I just wanted to show you guys these charts so you can see. And this is how this is pretty boring, but I'm a big data person, but this just shows you by zip code what the screening is we're doing and just what that impact looks like. So this is what I show my board, because they don't like all that other stuff. They just want to see this. They want to see no red. and if they see too much green, what do you guys think they said about the green? Your goal's too low. It wasn't that the goal was too low. It was just that that they were doing such a great job with getting it done. But they still made me raise the goal this year. So this shows you too, we went from a 52.6 in December 2022, when this office was first opened, up to a 61.7 in December of 2024, which is virtually unheard of. And so we've been pretty much knocking it out of the park with being able to provide the services and the guidance and leadership. The same thing for these. And these are all data metrics that we show them every single year. And as you can see, what I want you to take home from this is when you look at that last one in December, everything is pretty much green, which is what it should be. Now for 2025, you should have the red because you're starting out. And so, starting probably around June, we'll start to get yellow. But this kind of just shows you these targets. And this is what I report out every month in collaboration with our population health colleagues. Same thing, you'll see the annual increases that we have achieved. Usually it's about 2 to 3%. We have pretty much knocked it out of the box, but it's because of the fact that we weren't really engaging, but now that we're engaging, I tell my team, now gets to the hard point. It's easy to get people from 44 to 60, to get from 60 to 7 is a little bit of a different dynamic because of the fact now you're getting not the people who were just waiting on you to call them. Now you're gonna get to the people that say, I don't really know if I wanna know if I have breast cancer or not. That's a whole nother conversation. And so I tell the team as we move forward to our CDC 2030 guidelines, which is about 82, 83%, we're gonna start to see as we march up that way, we're gonna start to see a couple of more challenging things, but I know that the team is up for it. Well, I'll stop here and open it up. If you guys have any questions or anything, let me know. I'm always around for the most part. My office is up on the first floor. I'm pretty good with email, pretty good with texting. Just let me know. We'd love to do more with you guys. I do a lot with Dr. Haran and Dr. Manning already. And also Dr. Smith. So just let me know if there's anything that our office can do for you, especially in the areas of research and in the areas of really disseminating a lot of the good work that we're doing here. Thank you.
So I just want to give another round of applause for Dr. Wimberly. And this is literally a tiny percentage of all that she has going on and that she's thinking about for our patients. I hope you have been incredibly inspired like me. We are at the 1 o'clock point now. And if there is a burning question, I have my chair in front of me, so in case he has a burning question, I guess I'll just ask Dr. Wimberly one question, which is, if there was one piece of homework, one marching order or piece of homework that you could give to us as a leader in health outcomes, what would that be to give us an action item?
Thanks. Yes, I just ask people to really look at what you're doing on a day-to-day basis and how you can increase positive health outcomes of what you're doing. It could be something just very small, but it's going to take all of us to be able to really push this forward. And all of us have a unique opportunity to be able to advance positive health outcomes. It's just going to be a way that you have to kind of figure out how can you pull that out and how can you contribute. Yeah, I mean, I think that's going to be the main thing, because what I hear from a lot of workers is, Dr. Wimberly, I don't know how to do it. But really, you probably do know how to do it. It's just a matter of being able to tap into that to see what could be done. Oh, boy. All right, did anybody else have any burning questions before we end up? Well, thank you guys for coming.
And to the medical students in the room, just know that you too can be doing this kind of work too. When Dr. Wimberly and I were medical students, she was exactly like this, except she was a medical student. And a lot of your classmates, a lot of your co-residents, a lot of what you see now, you don't suddenly become somebody else. A lot of what you feel, what bothers you, what's inspiring you now will drive forward what you do next. I do want to acknowledge Grady Hospital and Yolanda's team who partnered with us in all of this and who also provided you all some nutrition, among other things. So thank you so much, Dr. Wimberly. I know that you have things calling you. We deeply appreciate you. And we'll provide the contact information for Dr. Wimberly's office should you have further questions.